So hello again, it's me again, and then you've got some different speakers. So I'm going to talk a little bit about demystifying the paediatric elbow. I love the paediatric elbow. It's my favourite pastime. Well, not my favourite pastime, but it's one of my favourite bits of the body in paediatrics. And what I will do to the attendees, I have actually written a paper about approaching the paediatric elbow, so I'm happy to share that with everyone going forward. So what I'm really going to talk about is history, examination, imaging, which is often a challenge with the paediatric elbow, and some of the common injuries that you'll see. What's always complicated with the elbow and makes all my juniors or colleagues or whoever anxious is all about the growth plates around the elbow, but we'll come on to that. If there's any questions or anything, pop it into the chat, and we'll take it nice and slowly. So upper limb injuries in children are massively common. They account for about 80% of injuries that we see in children's emergency department, and about 3% of them, so of those injuries, will be related to the elbow, and around 10% of those elbow injuries, surprisingly, will have some sort of neurovascular compromise. Like Jen was saying, and like I've said before, really, really important when you're approaching the elbow injury, the who, the how, the when, the what, the why, and the where. Lots of reasons why this is all important, but some, thinking about non-accidental injury, thinking about the mechanism, thinking about, are there any associated injuries that are going on? So, was it just simply that they've fallen off the monkey bars or off a slide, or actually is there something else that's going on? They've been hit by a car or something else going on, and just remembering actually it's not just the injury that you can see, to make sure that you're not missing anything else. And also, is the story plausible? Now, I don't want to always bang on about non-accidental injury, but does it make sense? Does the story make sense? And I think it's really important. And actually, how did they do the injury? Was it that they've fallen, or actually were they playing like cricket or tennis or using the elbow in some sort of way and they felt an injury or something happened? And that might help steer you towards what injuries are there. Handiness, really, really, really important. And got some of my paediatric colleagues in the audience, but sort of handiness sort of starts around sort of 3 to 5 years old, and sort of by the time children are in school, they will have a preference between right and left, and this is really, really important, because if it's their dominant hand, it may change how you manage the patient versus their non-dominant hand. Really, really important. I'm awful at remembering the handiness, so absolutely crucial that you document that in the notes. So this image of the teary child, really important. Like all injuries, it is really, really painful, and it's really important that you think about analgesia. So thinking about, simple analgesia such as Calpol, paracetamol, or ibuprofen, and then thinking about, if you've got access to it wherever you work, to your intranasal, be it fentanyl, diamorph, any of those sort of quick-acting opioids are really great. And actually, even more simpler than that, sometimes just putting them in a simple back slam or a soft cast or in a sling, just supporting the limb, can really, really help with analgesia. So really, really important. And I always say, whenever I do this talk and whenever I do talks around injuries, you will do your patients a disservice if you can't examine them properly. And even if that means, even if the department is really, really busy, wherever you are, give them some analgesia. And if you really can't examine them, give some time for that analgesia to take hold, and and then come back and examine them. And I often do that. You can put them back in the waiting room. They can see what happens, because what you don't want to miss is an injury such as a subtle neurovascular injury, which we'll come on to talk about. And really important that we get that examination right, so that our documentation is right, so that we're doing the best for our patients. Examination. So we've given some analgesia, we've thought about options, we've done some OBS, made sure that we've not missed any other injuries, and we've the hands up and down, we're thinking about your right and your left hand. As I said, 10% of these patients with elbow injuries, and this is just elbows, can have a neurovascular compromise. And what I mean by that is either a nerve injury which we'll come on to talk about, or a vascular injury, so that there might be a reduced blood supply. And different injuries, will have, around the elbow will give you more likely nerve or more likely neurovascular, but always be aware about this. And why is this important? Well, it's not only important, for the patient, because that could have a massive impact, but it's also important for the the trust and litigation. So missed supracondylar fractures, where there's a neurovascular compromise, and it's usually supracondylar fractures that will cause some neurovascular deficit. The range in litigation in recent years for payouts is somewhere between 27,000 to £250,000. And this is not meant to scare you or frighten you, but actually it's just a reminder to us all that it's really important. Not only are we documenting, but we're examining and making sure that we're doing the best for our patients. So Jen's briefly mentioned the infographic that I've done, and I'll come on to this. And this is, a concept. So rock, paper, scissors is a game that I'm sure you're all aware of, and is a way of quickly assessing gross, so big sort of neurological deficit in the limbs. So developed the rock, paper, scissors method sort of back in the early 2000s. And then there's other ways to add this on, and the OK was added, and I'll explain why in a minute. And whilst the concept of this is supposed to be around the management of supracondylar fractures, which are more likely to have these sort of neurovascular injuries, I think this assessment applies to both adults and children with injuries in the upper limb, and I'll come to talk about that now. So the rock. So when you make a rock or make that fist shape, it tests your median nerve. So rock is median nerve. Paper is radial nerve. Scissors is ulnar nerve. And I didn't change the OK on this, so always and OK is the anterior interosseous nerve. So the British Society of Orthopaedics, the paediatric element of it, there is a supracondylar fracture guideline that it states that, be it us or the orthopedics, but should be us, that any child with a supracondylar fracture needs to have each of these individual nerves documented in the notes to say that you've tested them and that they're normal. So remember that rock is median, paper is radial, scissors is ulnar, or you can get them to do sort of like a big starfish, like open their hands out. And then OK, not paper, OK is the anterior interosseous nerve. And the reason the anterior interosseous nerve is the last nerve, and it's a branch of the medial nerve, sorry, the median nerve, and it comes out before the carpal tunnel and supplies the muscles that make the OK sign. And all these four nerves need to individually be documented, particularly around supracondylar fractures. But also it should be any upper limb. And I've got some of my colleagues from my previous emergency department that I've worked at in Bangor up in North Wales on the teaching today, and I've implemented a stamp where you just stamp it in the notes and tick to say that you've checked it. And again, in Leicester here, I've done the same thing, and we've got a stamp in the department. And I do this for all upper limb injuries in children, just to make sure that we're thinking about that we've documented it. Again, so I've pulled this together into an infographic, and so the most common sort of injured nerve really is either the anterior interosseous nerve or the radial nerve, and they account for probably sort of most of the nerves that get injured with a supracondylar fracture. The median nerve can, and the ulnar nerve can, and I won't dwell too much on how that mechanism happens, but it's really, really important, particularly with elbows, but also I think any upper limb injury, to think about clearly documenting your nerves. And yeah, Katie, yeah, the infographic, I will when I send out the feedback later, and actually at the end of this talk you'll have the opportunity to download some of these resources, but I will share out that this is absolutely free, and you can do it as you wish with it, but it will get sent out, so don't worry. So, and Jen mentioned examining the limb, so looking, having a feel, although I've just realized those hands are a little bit handsy, and then moving, and just remembering that look, feel, move mechanism when you're examining the joint. Again, if they're not in got good pain relief on board, make sure that you give them some pain relief. Imaging. So I'm just keeping an eye on the chat here, and I can't see any obvious questions at the moment, but I'm keeping my eyes peeled. But yeah, so imaging. So there are 4 things when you're looking at a paediatric elbow X-ray that you need to think about, and it's really important that you think about making sure that you've got the elbow at 90 degrees. So the first question I always ask myself is, are the fat pads normal? So you're allowed an anterior fat pad, which is normal, which is here on the image on the left, but you're not allowed a posterior fat pad sign, which is the image on the right. And any posterior fat pad is a fracture until proven otherwise. And depending where you work, you know, if that's the only sign, more often than not, they're just put into a simple sling and followed up in local fracture clinic. And what the fat pad sign is swelling or an effusion around the joint that there may be an occult fracture that's there that we can't see. The next thing to think about is the anterior humeral line normal? So, you know, it should be as it is on the left here, going straight down through the sort of the first third there, not like the right picture where you can see it just that capitellum there is in the wrong place. And the next question to be asking yourself is the radiocapitellar line normal? So again, this is the line that's drawn right down the middle of the radius, and it should go through the capitellum and straight through in the middle, really. Not like the left-hand picture where you can see it's completely out of kilter and out of line, and that will make you very suspicious. And then ossification centres. So there are 6 ossification centres, and this image demonstrates you know, the ossification centres, and things should be apparent at different points. So if I move to this image, so the sequence that we always talk about is something called cretol or creto, depending where you are in the world. But essentially, you start with a capitellum, which is the first top image on the left, and that's usually should be present at a year. Then the next one that comes along is the radial head, and that's roughly about 3 years, followed by your internal epicondyle at 5 years. You've got your trochlea at 7 years. You've got your olecranon at 9 years. So this is the image here at the bottom. And finally, you've got your lateral epicondyle, which is at 11. And it's the order is more important than the ages. So they always come out in this order. And if one of them is missing, you need to be thinking about, well, actually, is it hidden somewhere because there's a fracture or an injury to the elbow? And I always has to come before T. So if you see the ossified T before the I, so if you see the trochlea before you see the internal epicondyle and there's been an injury, it's more than likely going to have been avulsed, and there'll be a fracture around there or avulsion around there. So it's don't get hung up on the ages. The ages are important to have in your in the background, but actually it's the order, and making sure you're thinking of that. So I'm just going to talk a little bit about some of the common injuries that we see, and I've not set up Menti on this, but if people want to just hazard a guess in the chat, that would be great. But the first injury I want to talk about before I show some X-rays is a pulled elbow. Now, I absolutely love pulled elbows, and I was talking to one of my friends who's a paediatric and an adult ED consultant up in North Wales the other day. And she was saying, like I was saying, this is probably one of my most favourite injuries because it's really simple and quick to make better, and often they high-five you out. And often, you know, the pulled elbow is, you know, there's been a pull mechanism. So I've seen it from, you know, swinging between parents' arms, being pulled up by their arms. I've seen it that a set of twins were fighting in the car, and even though their car seats were really far apart, they'd yanked each other, and they'd come in sort of with that classical sort of droopy arm, you know, that's down by the side, and you know, it was a pulled elbow. The key thing to think about the pulled elbow is, you know, when you approach the pulled elbow, again, you know, history, examinations, see what you think. Generally, pulled elbows aren't as swollen as, you know, a gross fracture of the elbow. They'll often try and use it a little bit. And if it's a good history and a good mechanism for what's happened, you know, give them some analgesia and try and reduce it. If after a couple of reductions you don't feel a click, or you don't think that they're using it, you know, leave them a little bit of time to go and play with the toys or whatever you've got, you know, play with mum and dad's phone or whoever they're with, and then come back to them. And if after a couple of attempts it's not worked, my general approach, and sort of what I've seen with lots of my colleagues, is that actually you might want to think, you know, have you got the right diagnosis, and actually do we need to x-ray this elbow? And again, you know, actually radiation, while I don't want to over irradiate a child, you know, an elbow x-ray is not that much radiation, and actually very occasionally I've got the diagnosis wrong and it turned out to be a radial head fracture or something like that. So really worth, you know, thinking about that elbow x-ray. And sometimes what can happen is that by the very fact that you're trying to position the elbow to get the right images for the x-ray, sometimes that will reduce the x-ray, reduce the pulled elbow. And you know, if when you've looked at the image they're not using the elbow and the x-ray looks absolutely normal, it's absolutely fine, I think, to think about sending them home with a sling if they can tolerate it, and then doing really good safety netting and saying, if things are not settling sort of in the next 24 hours, come back and see us and we can review it. And sometimes, you know, when they get home they have to put their clothes on or take their clothes off, and all of that will often put the elbow back. But really important, you know, thinking about good safety netting for the pulled elbow, particularly if you've got a normal x-ray and they're not playing with that arm. So here's an x-ray. Be interested to just hear what people think you know, this injury is, if you want to pop it in the chat. So this is a classic supracondylar fracture, and I've only given you the lateral here, which is a bit naughty of me. So yes, this is going to be a supracondylar fracture. Again, you know, thinking about making sure you've done that assessment, and this will need an above elbow soft wrap or plaster, you know, back slab, depending where you work, and we'll need, you know, follow up with the orthopedic team. This is, and I've annoyingly put the answer here, but this is a lateral epicondyle fracture. You can just see it here. I'm just circling it there on the screen. This is another common injury. It's easy to miss. And when I think about when you're looking at x-rays of the elbow, when you're deciding, is it the ulnar or is it the radius, always remember, one of my consultant colleagues, you know, the radius runs with the thumb. So the radius is always on the side of the thumb, and it's always on the outside. You know, it's the bone that's on the outside or lateral, and the ulnar is medial. So it's worth remembering that. This next one, which is a little bit blurry, but this is, where's my mouse gone? This is a medial epicondyle fracture. Again, they're quite difficult to miss. Sometimes they're easy to miss. There's lots of stuff going on there, and again, you know, these will often need, you know, orthopedic involvement and surgical involvement. And from an ED point of view, it's sort of referring them as your local policy is, and putting them in an above elbow back slab or soft wrap, depending where you work. So I'm just going to come to the end of my talk here, and just want to summarize some of the key points really. So always, you know, as Jen has talked about and I've talked about, you know, thinking about the key points of the history, the who, the when, the what's, the wherefores, and the whys, and always thinking, well, actually, does this history make sense? Really important to have the handedness, so the right and the left side, and remember analgesia. And even if you've got to give analgesia and come back, that's absolutely fine. You want to make sure that we examine that limb really well. In elbows, always remember rock, paper, scissors, okay, to test all your neurology for gross neurology. And along with that, you know, you need to be thinking about, you know, is there a good pulse present, and is the limb warm or is it cold? And that will change, you know, if it's a cold limb, you know, you need to do a reduction potentially of the injury. You know, check the pulse, which is my reminder, as I've said, and, you know, have a good look, have a good feel, and have a good move. When you're thinking about elbow x-rays, think about, are the fat pads normal? Is the anterior humeral line normal? Is the radiocapitellar line normal? And are the ossification centers normal? I'm happy to take any questions in the chat, and I'll send out the resources. You'll get the option now. So if you want to either go on this little link, or you want to use the QR code, there's a link resource folder which I've got lots of stuff in. I think it's still working. If there's a problem, just drop me a message, but I will send out this stuff with you, and I'll update the folder probably tomorrow with some other bits and pieces in it, so that you've got some good resources.